Bismillahirrahmanirrahim. I'm Dr. Mohamed Hassan, Associate Professor of Cardiology at Cairo University. And in my talk, I will focus on how to manage patients with atrial fibrillation. As we all know, AF is really very common with an estimated overall prevalence of around 3%, but this prevalence is significantly higher in patients with comorbidities like hypertension, diabetes, coronary artery disease, heart failure, valvular heart disease, and chronic kidney disease. And in those patients, AF is associated with significantly high mortality and morbidities. There is a twofold increase in the risk of all-cause mortality in women with atrial fibrillation and 1.5-fold increase in mortality in men with atrial fibrillation. And the annual risk of stroke or annual stroke rate in patients with atrial fibrillation is around 1.5% in anticoagulated AF patients, and 20 to 30% of all strokes are due to atrial fibrillation, either it's manifest or silent atrial fibrillation. There is also a poor quality of life for those patients with risk of recurrent hospitalization that reach up to 10 to 40% every year. The agenda of my talk will include firstly some important definitions for AF, and then the pathophysiology, and then how to diagnose AF in patients, and finally the management, either prevention of thromboembolic risk or rate control and rhythm control. Firstly, very important definitions that you should know, which is mainly related to the duration of AF. First diagnosed AF, it's just AF that has not been diagnosed before. It's the first attack diagnosed for the patient with atrial fibrillation. If this attack of AF is terminated within the first week, either it's self-terminated or by cardioversion, so it's called paroxysmal AF. In most cases, actually, it's terminated within 48 hours. But if it's lasted for 7 days, it's called paroxysmal AF. If it extended beyond the first week and extended and terminated after 7 days, so it's called persistent atrial fibrillation. If it extended more than 1 year, so it's called either long-standing persistent AF or permanent AF, depending on whether rhythm control strategy or rate control strategy will be adopted. If a rhythm control strategy will be adopted for atrial fibrillation lasting 1 year or more, for example, by ablation or cardioversion, so it's called long-standing persistent AF. But if it's persisted more than 1 year and rate control strategy will be adopted, so it's called permanent atrial fibrillation. Importantly, AF also is classified to either valvular AF or non-valvular AF. Valvular AF is AF in the setting of moderate to severe mitral stenosis, mean mitral valve area less than 1.5, or in the presence of a mechanical heart valve. Non-valvular AF mean that AF in absence of moderate to severe mitral stenosis or a mechanical heart valve. And this does not imply the absence of valvular heart disease. For example, if the patient has severe mitral regurg or aortic stenosis and AF, so it's called non-valvular AF. This is because that in most of the new clinical trials on new oral anticoagulations, up to 20% of patients were enrolled with various valvular defects like mild mitral stenosis, mitral regurgitation, aortic stenosis, and tricuspid regurgitation, and you can use new oral anticoagulants in those patients. So this is really very important to know that non-valvular AF does not imply absence of valvular heart disease. It's only absence of moderate to severe mitral stenosis or a mechanical heart valve. What about pathophysiology of AF? We know that there is some genetic predisposition, and there is many risk factors for AF like diabetes, heart failure, obesity, coronary artery disease, hypertension that lead to structural remodeling of the atria by activation of fibroblasts, enhanced connective tissue deposition that lead to some fibrosis, also fatty infiltration, amyloidosis, infiltration with inflammatory cells, myocyte hypertrophy and necrosis. So all this lead to structural remodeling of the atrium that lead to some functional and electrical remodeling of the atrium due to electrical dissociation between the muscle bundles with some local conduction heterogeneities that favor re-entry, that lead to more re-entry and lead to the development of atrial fibrillation. The presence of atrial fibrillation lead to some stasis of blood in addition to expression of prothrombotic factors on the atrial endothelial surface with activation of platelets and inflammatory cells that increase the risk of development of thrombus and embolization, increase the risk of thromboembolism, and increase the risk of stroke. What about the diagnosis? Sometimes AF may be silent, but if the patient is symptomatic, either with palpitation, dyspnea, chest tightness, poor exercise capacity or poor exercise tolerance, so you should classify his symptoms according to the Heart Rhythm Association Symptom Scale, which is a class 1 recommendation to use this modified symptom scale to categorize this patient either with score 1 if he's asymptomatic, 2A if there is mild symptoms as not affecting his normal daily activity, 2B if it's just moderate symptoms is not affecting his normal daily activity, but he has some symptoms troubling his life, 3 if his normal daily activities started to be affected and with the severe symptoms, so it's a scale score 3, and score 4 if the symptoms are disabling and lead to discontinuation of his normal daily activity. Importantly, if the AF episodes are silent, so screening of at-risk older population is very important, because if an older patient has some risk factors and silent AF, this patient is at a risk for developing stroke. And in a study that included more than 100 participants, they found undiagnosed atrial fibrillation in 1.4% with a number needed to screen of 70. So screening of at-risk older population either by pulse palpation or resting ECG is important, because if you diagnose atrial fibrillation and it has a high Health-VAS score, so you should give anticoagulation to prevent stroke in those patients with all its consequences. If the patient, in some cases with cryptogenic stroke or TIA, it's very important to screen for atrial fibrillation either by ECG or even if the ECG is fine, you should, as a class 1 recommendation, to do Holter for at least 72 hours to pick up if there is a runs of atrial fibrillation, which keep this patient at a risk, and you should start oral anticoagulation to prevent recurrent stroke. And if the Holter or the external ambulatory monitoring is inconclusive and you are still doubting, so there is a class 2 area recommendation to implant a cardiac monitor or a loop recorder to optimize detection of silent atrial fibrillation. If your patient has a pacemaker or ICD, and during interrogation of the device you find an atrial high rate episodes, this is very important to evaluate firstly your patient to see if it is atrial fibrillation or not, which makes the patient eligible for taking new oral anticoagulation and preventing the risk of stroke in this patient. So if you are during the interrogation found an atrial high rate episode with defined as an atrial episode rate more than 180 beats per minute and lasted for more than 5 to 6 minutes, so this is really very important. Firstly, you should assess whether this patient is eligible for oral anticoagulant or not, if his Health-VAS score is high or not. If it's high and this patient is eligible for oral anticoagulation, so this needs more evaluation to verify the presence of AF, either by doing resting ECG, Holter, or review the interrogation and device electrograms carefully to detect atrial fibrillation. If AF is diagnosed, so this patient definitely you should start oral anticoagulants. If not, so you should discuss with your patient the risk and benefits and assessing the risk of bleeding in this patient, and then it will be a case by case or individualized decision whether to start anticoagulant in patients with detected atrial high rate episodes with no documentation of atrial fibrillation. But if from the start the patient is not eligible for anticoagulation, so this patient at a low risk of stroke, and mean that there is no need for antithrombotic therapy. Let's move to the management of patients with atrial fibrillation. There are 5 domains which characterize the management of atrial fibrillation. Firstly, if the patient is hemodynamically unstable, he has refractory angina, severe symptoms, so you should rate or rhythm control this patient acutely to relieve his symptoms and to improve his hemodynamics. The second domain is you should search for the presence of precipitating factors, like, for example, cytotoxicosis or electrolyte disturbance, because this need to be treated in order to manage your patient. And then assessing the risk of stroke and assess whether your patient is available for, is eligible for taking oral anticoagulants or not. And then finally, heart rate control or rhythm control of these patients. Let's start with prevention of thromboembolism, how to prevent thromboembolism, how to assess the risk of thromboembolism in patients with atrial fibrillation. Valvular AF is considered an indication for long-term anticoagulation with warfarin. This why it's considered a single, separate entity. Patients with moderate to severe mitral stenosis or mechanical heart valve, this need a long-term anticoagulation with warfarin, with no place for the new oral anticoagulants in these patients. For patients with non-valvular AF, you should calculate what's called SHADS-VAS score, because this score is a validated score to assess the risk of stroke in patients with non-valvular atrial fibrillation. This is a score or the risk calculator. If C stands for congestive heart failure, H for hypertension, A if the patient age 65 to 74, so he take 1 point, but if he's 75 years or older, so he take 2 points. D is diabetes, S for stroke or any thromboembolism. If there is a TIA or any peripheral embolization, so he take 2 points. Vascular disease take 1 point, mean coronary artery disease, like previous myocardial infarction, peripheral artery disease, or aortic plaque. So this gives them 1 point. And finally, 6th category, if the female patients, female gives actually them 1 point. So firstly, calculate the SHADS-VAS score. It's very important here to discuss the relation between AF and the gender. The incidence and prevalence of AF in women actually is lower than men. And importantly, female gender is associated with a higher risk of stroke compared to men if there is additional stroke risk factors. But if there is no other AF risk factors, if a female gender, which is not diabetic, no hypertension, her age is less than 65, and there is no history of stroke, so the risk of stroke is similar to men. This is really very important, and this changes a little bit the management of AF patients in new guidelines. Importantly, you should also assess the bleeding risk, because you know that you are giving the patient anticoagulants, and importantly, you need to prevent stroke, but importantly, you need to avoid significant major bleeding or intracranial bleeding in those patients. And one of the famous scores is the Hasblet score. H stands for hypertension, but not only hypertension. If the hypertension score is controlled, so it's not included in the score. Hypertension, if the systolic blood pressure is more than 160 millimeter mercury, so this gives him 1 point. Abnormal liver function mean that the liver enzymes elevated more than 3 folds and the bilirubin more than 2. If it's satisfying this criteria, so give him 1 point. Abnormal renal function also, if the serum creatinine is high, if it's more than 2, for the patient in dialysis, so also you take 1 point. Stroke, 1 point. Bleeding, if there is history of bleeding. Labile INR, which mean poor TTR, time in therapeutic range. If the time in therapeutic range is 60%, so it's 1 if the patient on warfarin. Elderly, 1 point. Drugs, 1 point. Drugs mean non-steroidal anticoagulants or dual antiplatelet or antiplatelet agent. And alcohol also, if the patient is receiving alcohol or taking alcohol, so this increases the risk of bleeding and they give him additional point. And if the Has-Blood score is more than 3, makes the patient at a high risk for bleeding. Let's move to the guidelines. So patients with valvular AF receive warfarin therapy for life. Patients with non-valvular AF need assessment of the risk score, the thromboembolic risk with the Schwarz-Bass score, and accordingly you judge whether your patient will take anticoagulation or not. If the Schwarz-Bass score 2 or more in men or 3 or more in women, so this patient need life-term oral anticoagulants, either warfarin or the new oral anticoagulant. The level of evidence is A for warfarin, and the level of evidence B for the new oral anticoagulants. But importantly, there is now a recommendation that new oral anticoagulants are recommended over warfarin. It's better than warfarin in patients with non-valvular atrial fibrillation because there is a significantly better risk-benefit ratio. The risk of bleeding is less with the new oral anticoagulants. In patients with non-valvular AF, it's recommended over warfarin. And importantly, you give anticoagulants regardless and irrespective of whether AF is paroxysmal, persistent, or permanent. So if the patient now has sinus rhythm with a history of AF, so the risk of thromboembolism is the same in paroxysmal and as equal as patients with persistent or permanent atrial fibrillation. And importantly also, the risk of stroke with atrial flutter is the same as atrial fibrillation. So anticoagulant therapy is recommended according to the same risk profile used for atrial fibrillation. For patients with atrial fibrillation with Schwarz-Bass score 0 in men or 1 in women, mean that men with no risk factors for AF or women with no also other risk factor for AF, so it's reasonable to omit anticoagulant therapy and not to give anticoagulant therapy. And this recommendation is clear and quite different from the 2016 European guidelines, which stated that there is a class 2A recommendation to give oral anticoagulants if the Schwarz-Bass score is 1. So now if the Schwarz-Bass score 1 in women, it's reasonable not to give anticoagulation in those patients. If the Schwarz-Bass score is 1 in men and 2 in women, so there is a class 2B recommendation. You may consider giving oral anticoagulants in those patients. So I think in this group of patients, you should assess the bleeding risk. If the bleeding risk is high, definitely not to give anticoagulation because it's a class 2B. If there is significantly, the risk of bleeding is low, so you may consider giving anticoagulation in those patients. In patients with moderate to severe chronic kidney disease, you can give one of the new oral anticoagulants, but with a reduced dose. For example, with the rivaroxaban, if the GFR creatinine clearance between 50 and 30, so you can give the 15 milligram dose instead of the recommended 20 milligram dose. And with edoxapan also, if the creatinine clearance between 50 and 15, so you can give the 30 milligram instead of the 60 milligram. With apixaban, it's recommended to give the 2.5 milligram twice daily dose if at least 2 of these three points are present in your patient. So if the age 80 or more, body weight 60 or less, or serum creatinine 1.5. So if the patient has two of these three, you can start the reduced dose of apixaban, which is 2.5 milligram twice daily. But patients with end-stage renal disease or those on dialysis, you can give only either warfarin or apixaban. This is actually the two anticoagulants who are studied and proved good efficacy and safety in patients with end-stage renal disease and or those patients with dialysis. It's very important to know how to manage anticoagulation if your patient developed TIA, ischemic stroke, or intracranial hemorrhage. So if your patient developed TIA, so you can start oral anticoagulation 1 day after the acute event. But if the patient has a stroke, so it's very important to classify or stratify the stroke based on the NIHSS score, which is the National Institutes of Health Stroke Severity Score. This actually assesses the severity of score. If it's less than 8, so you can start oral anticoagulation 3 days after the acute event. If the stroke is moderate, meaning the score between 8 and 15, so you can start 6 days after the event, after doing an imaging to rule out hemorrhagic transformation of the brain infarction. If the stroke is severe with a score 16 or more, so anticoagulation can be initiated only 12 days after the event and after also excluding hemorrhagic transformation in a brain imaging at day 12. There is other clinical factor that may guide your decision and may favor either early or delayed initiation of oral anticoagulant other than the stroke severity score. It's either the size of brain infarction, if actually the patient has a high risk of recurrent stroke, if he has cardiac thrombus, for example, is there a thrombus in the LV or the thrombus in the heart, which make him at a high risk, so this favor early initiation. If there is no hemorrhagic transformation, if he's young, stable, with controlled AF, which is quite different from an elderly patient, neurologically unstable, the blood pressure is uncontrolled, with some hemorrhagic transformation, this favor delayed initiation of oral anticoagulants. For those patients who develop intracranial bleeding, so there is no way mostly you will delay initiation of anticoagulant therapy and you can initiate or resume oral anticoagulants after 4 to 8 weeks, but many factors need to be considered to support whether to reinitiate or not to start oral anticoagulant later on, and you may think of a non-pharmacological way to prevent the risk of stroke by left atrial appendage occlusion. So there is, if the patient is older aged, uncontrolled hypertension, if he has actually severe intracranial bleeding, if he has a chronic alcohol abuse, if he need also antiplatelet therapy after PCI. So there is many factors. There is actually discussion should be done between the neurologist and the cardiologist in a multidisciplinary team to decide whether to start to reinitiate again oral anticoagulants or not, and when. But the rule, it should be that anticoagulation will be initiated after 4 to 8 weeks after considering all these points. If we encountered a patient with atrial fibrillation that underwent PCI and he needs antiplatelet therapy, so how we will manage this? Because we know adding antiplatelet therapy to anticoagulant therapy will increase the risk of bleeding in these patients. And we know that AF actually it's common in acute coronary syndrome, and the incidence range between 10 to 12.21%, and it increased with the patient age and severity of MI. And it's associated with poor prognosis compared to those with sinus rhythm, associated with increased in-hospital mortality, in hospital, and the 30-day mortality, and also the 1-year mortality. So it's very important in those patients to assess both the ischemic risk and the bleeding risk. Ischemic risk regarding the coronary ischemic risk. Many factors actually here can guide the ischemic risk, whether it's left main stenting or strategic PCI. Which strategy is used? Is it a two-stent technique? It's a mini crush or Kilot technique, or it's a simple PCI? The length of stent, the diameter of stent, many factors actually will help you to assess the risk of stroke. On the other hand, you should assess the risk of bleeding and decide at this step whether you are concerned with the ischemic risk more, or you are concerned more with the bleeding risk. If you are concerned more with the ischemic risk, with the left main stenting, complex PCI, patient with acute coronary syndrome, and the risk of bleeding is not high, so here you need to give a triple therapy, dual antiplatelet with the anticoagulant for up to 6 months, and then shift to dual therapy, omit one of the antiplatelet, and then after 1 year, you continue only on a monotherapy with oral anticoagulant. But if you are concerned with the bleeding risk, there is a significantly high bleeding risk in a female, a frail patient with anemia, recurrent bleeding, and you are not concerned more with the ischemic risk, so you can give triple therapy only for 1 month, and then shift to dual therapy, and then monotherapy with oral anticoagulant after 1 year. If your patient with taking oral anticoagulant and is going to do non-cardiac surgery, for example, and he is going to he were asked from his doctor to stop anticoagulants. So it's important to know how to interrupt and how to bridge the therapy with unfractionated heparin or low molecular weight heparin. For example, if the patient has a mechanical heart valve and atrial fibrillation, so definitely this patient needs bridging with heparin, because he has a high risk of thrombosis and high risk of thromboembolism, so he should bridge with unfractionated heparin. But if patient with atrial fibrillation does not have a mechanical heart valves, non-valvular atrial fibrillation, so the decision here mainly related to assessing the risk and balance between the risk of stroke, the risk of bleeding, the duration of time that the patient will not be anticoagulated, and here you can individualize your decision. Importantly, if your patient has now life-threatening bleeding, it's important now we have some factors or drugs that can reverse the anticoagulant effect of dabigatran, for example, by the idarucizumab, or the andexanate alpha for rivaroxaban. Let's move to the non-pharmacological stroke prevention. We know that you can prevent the risk of stroke by giving anticoagulants, but on the other hand, you can also prevent the risk of stroke by occluding the left atrial appendage, which is the main site of thrombus formation in more than 90% of cases. And percutaneous left atrial appendage occlusion may be considered in patients who are at increased risk of stroke, but has contraindication to long-term anticoagulation. This is a class 2B recommendation. Now, when we look at the data of the left atrial appendage occlusion, we know that we have two landmark trials studying the Watchman device, or the left atrial percutaneous left atrial appendage occlusion, which is the PROTECT-AF and the PREVAIL studies. And here it's a meta-analysis which combine the data from the two studies and showed that percutaneous closure of the left atrial appendage is associated with significantly lower hemorrhagic stroke. However, it's associated with significantly higher risk of ischemic stroke, which is, but after excluding the peri-procedural events which is mainly related, we know, to the experience of the operator. We know that this procedure is associated with some complications, stroke, cardiac tamponade. After excluding these events, the risk of ischemic stroke is quite similar between the two groups. And importantly, the approval for this device is mainly restricted to patients who have contraindication to long-term anticoagulation. You know that you should give actually oral anticoagulants for those patients for short term after the device implantation. And if there is no leak and if the device is stable with no leak between the left atrial appendage and the left atrium, so you can omit and you can stop the anticoagulation for life. What about cardiac surgery? Surgical occlusion of the left atrial appendage at the time of surgery may be considered in order to decrease the risk of stroke, which is a class 2B recommendation. You can close it at the time of surgery. Now, let's move to the next domain, which is how to control the ventricular rate and the ventricular response in patients with. If your patient is hemodynamically unstable or has severe symptoms, so he needs rapid control of heart rate. If the LV ejection fraction is normal or 40% or more, so you can start beta blocker. You can give IV beta blocker. You can give also calcium channel blocker. You may need to add digoxin if the resting heart rate still tachycardic and the ventricular rate is high. But if the LV ejection fraction is impaired and the patient ejection fraction is less than 40%, or if there is a signs of heart failure with reduced ejection fraction, so you may give small dose of beta blocker, but you have an option to start definitely amiodarone to allow rapid stabilization of his hemodynamics. And you may also give, you can start digoxin to control his heart rate. But importantly, you should perform echocardiography to firstly assess the LV ejection fraction at lower rate of atrial fibrillation, because the LV may be impaired at a very high rate, but after control of AF, you may find that the LV ejection fraction is improved and the resting ejection fraction is relatively normal. In chronic cases, if the patient has a chronic heart failure, no need for acute control, you may start oral agents like beta blocker, bisoprolol, carvedilol, and we know the recommended doses for either beta blocker, calcium channel blocker, and also digoxin, and also amiodarone can be used also for rate control. Now, how can you do a rhythm control or cardiovert the patient with if the patient is hemodynamically unstable, so you should achieve this rapidly by urgent electrical cardioversion. If he is hemodynamically stable, so you will discuss with your patients the different methods available, either to go for elective electrical cardioversion or pharmacological cardioversion, and selecting the drug or the agent that you will use to cardiovert your patients depending on his problem list and his clinical profile. If the patient does not have any structural heart disease, no normal echo, no significant LVH, and no coronary artery disease, so you can give him propafenone or flecainide to cardiovert him. But if the patient has coronary artery disease, severe heart failure, LVH, so you give better intravenous amiodarone, or also vernicalant in patients with coronary artery disease with no severe heart failure. Once you cardiovert your patients, so you select the drug that you can use to maintain sinus rhythm in order to avoid recurrence of atrial fibrillation. So If the patient has no or minimal signs of structural heart disease, so you can give propafenone. If the patient does not have LVH, does not have coronary artery disease, you can give propafenone. If the patient has only coronary artery disease and no significant LVH, you can give sutalol. And you can discuss with the patient also that you have a class 2A recommendation to do a catheter ablation. But if the patient has coronary artery disease, significant LVH, abnormal LVH, so you can give here amiodarone or dronidarone. Sutalol can be given in patients with coronary artery disease, but if he has a significant LVH, it's not recommended to give sutalol. If the patient in heart failure, so you can give either amiodarone or go for catheter ablation. Importantly, how to manage anticoagulation during rhythm control. If the duration of atrial fibrillation is more than 48 hours, importantly, the patient should be anticoagulated either with warfarin or with target INR 2 to 3 or with the new oral anticoagulant for at least 3 weeks before cardioversion and for at least 4 weeks after cardioversion. Regardless of the CHA2DS2-VASc score and regardless whether the patient will need long-term anticoagulation or not. If you will not do this, so you can do transesophageal echo and exclude the presence of left atrial appendage thrombus, and then if there is no thrombus, you can do a cardioversion, either electrical or pharmacological. But if the duration is definitely less than 48 hours, this is very important, because if it's indefinite, so assume that it is more than 48 hours and you should do either 2EE or anticoagulation for 3 weeks before cardioversion. If the duration is definitely less definitely less than 48 hours, and the patient actually has CHA2DS2-VASc score 2 in men or 3 in women, which means that he needs long-term anticoagulation, so we should give either heparin or one of the new oral anticoagulants as a class 2A recommendation, and then you continue for long-term anticoagulation. If the patient has an atrial fibrillation less than 48 hours and his CHA2DS2-VASc score is low, 0 in men or 1 in women, so it's a class 2B. You can actually do a cardioversion without anticoagulation, and you may consider giving anticoagulation during a cardioversion, because this AF is duration is small and this patient will not need long-term anticoagulation. This is what the guidelines say. But you should know that the 48-hour rule has also been questioned, because delay to cardioversion of 12 hours or longer from symptom onset still associated with a greater risk of thromboembolic complications compared to cardioversion of less than 12 hours. So the risk of, if the AF persisted more than 12 hours, the risk of thromboembolism reach up to 1.1% compared only to 0.3% if it's less than 12 hours. So the rule of 48 hours is still questioned. And this risk of stroke increase if the patient has many other risk factors like age more than 75 or specifically in women. So the data supporting the safety of the current practice of cardioversion of AF without oral anticoagulation for the patients with AF duration less than 48 hours are limited. So I prefer, if you have the option to give oral anticoagulants to cardiovert AF, even if the duration less than 48 hours and even if the risk of stroke is less, you can do this as long as there is no significant increase in the bleeding risk. There are 2 recent, actually, retrospective studies demonstrated that the risk of thromboembolic complications after cardioversion of AF lasting less than 48 hours is in the range of 0.7 to 1.1%, which is higher actually in patients with other risk factors. So in absence of a randomized trials, the risk of thromboembolic events should be weighed against the risk of bleeding, and the decision better to be individualized in those patients. So you can maintain sinus rhythm by pharmacological therapy. And now we have a class 2B recommendation also to maintain sinus rhythm and to do a catheter ablation in patients with symptomatic heart failure with atrial fibrillation who have reduced LV ejection fraction to potentially lower mortality and also to reduce the hospitalization for heart failure. What about AF ablation by doing a radiofrequency ablation during surgery? At the time of doing an open heart surgery like CABG or valve surgery, so you can, if the patient has symptoms and you prefer to control the rhythm and to maintain sinus rhythm, you can, after discussion, do an AF surgery and ablation in the atrium with also surgical left atrial appendage exclusion. And now we have a class 2A recommendation to do such a radiofrequency ablation at the time of surgery in order to maintain. And here is the guidelines. It's a class 1 recommendation if the patient has a symptomatic paroxysmal AF. So if he is still symptomatic with a recurrence of AF on antiarrhythmic therapy, you may go for an EP ablation by an experienced operator in an experienced center. And also as a class 2A recommendation to do an ablation for the common atrial flutter and ablation of the cavotricuspid isthmus. So this also can help. And there is a class 2 recommendation to do a catheter ablation for atrial flutter. But it's very important to know that even after ablation and maintaining sinus rhythm, this patient should receive oral anticoagulants for at least 8 weeks after catheter ablation and also surgical ablation. And the long-term anticoagulant should be continued indefinitely according to the SHADS-VAS score, even after successful catheter or surgical ablation. Finally, we'll talk on a specific situation, which is post-operative atrial fibrillation, especially atrial fibrillation post-cardiac surgery. We know that it's really very common and that's what occur in 15 to 45% of patients, and is associated with increased length of hospital stay, early stroke risk, and 30-day mortality. Patients with an episode of post-operative atrial fibrillation have a twofold increase in cardiovascular mortality and substantially increased risk of future AF and ischemic stroke compared to those who remain sinus rhythm after surgery. And importantly, oral anticoagulation at discharge has been associated with reduced long-term mortality in patients with post-operative atrial fibrillation compared to with other patients, but this is without any evidence from randomized control trials. How to manage patient with post-operative AF? We know that oral beta blockers perioperatively, either preoperative or post-operatively, is associated with decreased risk of post-operative atrial fibrillation after cardiac rhythm. We know that actually occur late. It happens actually between the 3rd and 5th day. So initiation of beta blocker early after surgery is associated with decreased risk of developing post-operative atrial fibrillation. You can restore sinus rhythm either by electrical or pharmacological cardioversion. Long-term anticoagulation should be considered in those patients who are at a risk of stroke, considering definitely the risk of stroke and the risk of bleeding. There is a class 2A recommendation even to give perioperative amiodarone as a prophylactic therapy, but actually in current practice, you give only beta blocker, and if the patient develop atrial fibrillation, you can manage it either by electrical cardioversion or pharmacological cardioversion. Thank you. I think it's time for questions. هل في أي حد عنده سؤال؟ في حد عنده سؤال؟ الو.
يا دكتور محمد، لو في حد عنده اسئله دكاتره ممكن يفتح المايك ويسال الدكتور محمد.
اوكي، لو في اي حد عنده سؤال في البرزنتيشن ممكن يسال. لو في حاجه مش واضحه انا معاكم، اتفضلوا. لو ما فيش اسئله، طب دكتور محمد ثابت عندك سؤال؟
لا يا دكتور محمد.
الصوت مش واضح، لو نقدر نعلي الصوت.
لا الصوت كان واضح.
البرزنتيشن كانت واضحه. كان في، خلينا نشوف في حاجه على الشات. ما فيش اي questions. حد عايز يكتبها على الشات او actually ممكن يقولها لنا على طول دلوقتي. It's time for discussion. لو في اي حاجه مش واضحه regarding اي point، سواء كان في when to give anticoagulation, how to manage anticoagulation في عيانين with PCI, how to do rhythm control. يعني اي حد really open for discussion. اي حد عنده سؤال يساله. It's an open discussion now. يبدو ان everything is clear. ف خلاص اوكي. لو ما فيش حد عنده سؤال فاحنا ممكن يعني
في سؤال واحد بس جه في الشات يا دكتور.
اوكي، ثانية واحدة. طب ممكن تقولي السؤال يا دكتور محمد عشان
في الشات
على الشات. اوكي. Is there any place to fill in pocket in the guidelines? Okay. This is a good question. امتى نلجأ للبيل pocket in our clinical practice؟ أول حاجة if any the only drug actually available now for rhythm control as a pill in pocket, it will be the ritmonol as we know. فلو العيان presented with atrial fibrillation, the first attack should be in hospital. يعني لازم نadmit العيان the first time in hospital and then try ritmonol. ولازم الريتمونورم يبقى successful، يعني فعلا هو ينجح in the first episode in hospital ان هو يبقى ان هو return الرhythm into sinus rhythm without evident complications او widening للQRS complex. وفي الحالة دي انت بتاسس with the patient هل هو عايز ياخد drug to maintain first attack to maintain rhythm ويمنع انه يجي له attacks ثانيه، ولا يفضل without any drugs to maintain sinus rhythm وياخد بس الريتمونورم as a pill in pocket. ودي احنا بنستخدمها زي ما انتم عارفين لو الاتاكس are not frequent. لكن لو العيان بيجي له frequent episodes of atrial fibrillation فit's better ان هو ياخد الريتمونورم regularly to prevent ان هو يجي له atrial fibrillation. لكن لو الاتاكس are infrequent ولو الريتمونورم او البروبافينون was successful ان هو يكارديفيرت البيشنت without symptoms، بس لازم تبقى اول مره تبقى in hospital، خلاص you give him الريتمونورم ان هو يستخدمه as a pill in pocket. بس طبعا انتوا عارفين واهم حاجه انه you should give a beta blocker before ريتمونورم في الكارديوفيرجن. ليه؟ لان الريتمونورم بيعمل ايه؟ الريتمونورم بيقلل الاتريال ريت بس بيحسن وبيزود الايفي كوندكشن. فلما بيزود الايفي كوندكشن ممكن يقلل الريت ويدخل البيشنت into atrial flutter with a high rate before cardioversion. ودي فبالتالي ممكن يزود الفنتريكولار ريت في الاول، وده ممكن يؤدي الى هيمودايناميك انستابيليتي في العيانين. فايتس بيتر ان البيشنت في الحاله دي ياخد انا مثلا what I usually give ان انا اخليه ياخد bisoprolol 2.5 ومثلا 15 minutes ياخد بقى 2 tablets of ritmonorm and then if it's not cardioverted ياخد another 2 tablets. Okay. Any more questions or comments? طيب انا استمتعت معاكم واتمنى يكون المحاضره كانت كلير واستفدتوا النهارده. Thank you everyone and thanks Dr. Mohamed Sabit for يعني managing all the technical points. شكرا وان شاء الله تكونوا استفدتوا النهارده. Thank you.
شكرا يا دكتور محمد.
شكرا.